Hello, the greetings of the day. This is Dr. Pankaj Jain. I am Chief Physician, Director, and Head of the Department of Internal Medicine, Ivan Multi-Speciality Hospital and Research Center, Muzaffarnagar. I am practicing in internal medicine as a physician for last over 35 years. During these years, I have seen the changing pattern of the treatment of various ailments, especially diabetes. The first line treatment for the newly diagnosed diabetic patients, their add-on medicines, their criteria all have changed drastically during these years. I consider myself still a student of internal medicine and try to learn newer therapies, newer medicines, and try to incorporate all these things, try to translate them into my prescription to the best of the benefits for my patients. With this concept, I am going to present a very, very interesting case with all of you where, in the light of the latest studies and researches, I was able to help my patient in controlling her glycemic status and avoiding complications. So, here's the case. This patient, Ms. Kamal, 54-year-old female, type 2 patient for last 6 years. During the routine checkup, she complained of the generalized weakness. There is history of hospitalization for acute coronary syndrome 1 year back, and she went through PTCA also. There's family history. Father had MI and underwent CABG surgery 5 years back. Her BM 29.7, body weight 71 kg, height 155 centimeters, blood pressure 146 upon 86 millimeters of mercury. Her HbA1c is 8.4%. Lipid profile LDL-C 75 milligram percent, HDL 37 milligram percent, triglycerides 156, total cholesterol 168 milligram per deciliter. Her eGFR is 65 ml per minute per 1.73 meters square. Urinary albumin creatinine ratio is 300 milligram per gram. Her 2D echo shows mildly dilated LA and RA with LVEF, left ventricular ejection fraction, slightly decreased 50%. She was on the medication when she came to me. She was on metformin 1 gram twice a day, glimepiride 4 milligram once a day, losartan 50 milligram OD, atorvastatin 40 milligram once a day, amlodipine 5 milligram once a day, chlorthalidone 12.5 milligram per day, metoprolol sustained release 50 milligram daily, aspirin 75 milligram at bedtime. She has sedentary lifestyle and is trying to avoid weight gain and exercises few times in a week. She is frustrated that her weight is unchanged in spite of all efforts, and she is not controlled. Her glycemia is not controlled, her blood pressure is not controlled, so she is not happy with this. With these things, she came to me. She also complains of high glycemic events at times. So, friends, challenges in this patient were uncontrolled hyperglycemia, obesity, hypertension which is not controlled, history of previous myocardial infarction, and microalbuminuria. All these uncontrolled challenges means she is a high-risk patient. So before starting with the treatment, let us discuss something. That is, type 2 diabetes is a complex disease. We all know it's a disease of chronic hyperglycemia which gradually increases over time. Type 2 diabetes is also associated with the severe risk factors such as abdominal obesity, arterial hypertension, dyslipidemia, thrombogenic status, low-grade inflammation, and oxidative stress. All these risk factors, they accelerate atherothrombosis, resulting into coronary artery disease, stroke, peripheral artery disease. Almost two-thirds of the patients with the type 2 diabetes will die from CVD and almost half from the CAD. A better management during the last 2 decades has allowed the reduction in the incidence of CV complications. Yet, risk remains high with the patients of type 2 diabetes. CKD and heart failure has also become complications of major interest. The ADA recommendations 2019 says CV protective agent as the first add-on after oral hypoglycemic agents in patients with type 2 diabetes. In 2015, The era of evolving dimensions of the cardiovascular care in type 2 diabetes management began with the EMPA-REG outcome study, which demonstrated significant benefits of empagliflozin in the risk of heart failure by 35%. Among participants with a baseline history of heart failure, empagliflozin was associated with a numerically lower rate of heart failure and CV death with no heterogeneity between participants with or without baseline heart failure. Among participants who had initial heart failure, empagliflozin was associated with a near two-fold reduction in the risk of subsequent CV death. It is possible that SGLT2 inhibitors might prevent the development of heart failure in diabetic patients. Positive top-line results of the Emperor Reduced have been recently published in patients with a heart failure with reduced ejection fraction with and without diabetes. The EMPA Heart Cardiolink 6 study demonstrated that empagliflozin could produce early reverse cardiac remodeling in type 2 diabetic patients and stable coronary artery disease. In a sub-analysis from EMPA-REG study, empagliflozin decreased new onset of worsening of nephropathy by 39% on the top of the ARAS blockade therapy. The addition of empagliflozin was associated with slower progression of the kidney disease. The CV and the renal benefits seems to be maintained independent of eGFR level, even with the progressive eGFR decline. Because of the unique mechanism of SGLT2 inhibitors, it has a range of effects that may translate to potential benefits beyond glycemic control. I repeat, benefits which are beyond glycemic control, especially in diabetic kidney disease patients. It's associated with the pleiotropic effects, including reductions in the blood glucose concentrations, natriuresis, and decrease in the blood pressure and body weight. Linagliptin, it has a unique profile with primarily non-renal but hepatobiliary route of elimination, requiring no dose adjustments in the patients with CKD. The Carmelina study, which is a linagliptin CV outcome study, it confirmed it reduce the progression of albuminuria, 14% reduction in the progression of albuminuria. In fact, the SGLT2 inhibitors is a class of novel oral glucose lowering agents that mediates glucose lowering action by increasing urinary glucose excretion via inhibitions of the sodium glucose co-transporter 2 in the proximal convoluted tubule of the kidneys. The salutary effect is it in its ability to act independent of the insulin secretion and action and render it suitable to administer at any stage of the disease. The DPP4 inhibitors, they exert its glucose lowering effect by elevation of the incretin hormones and subsequent augmentation of the glucose dependent insulin secretion and inhibition of the glucagon release. And the combination of these two agents, that is the SGLT2 inhibitor with the DPP4 inhibitors, has potential to show the additive glycemic control due to its complementary effects. With all these data and facts in the mind, I added empagliflozin with limagliptin combination in this patient. And the results were surprisingly pleasant after 6 months. Her HbA1c became 7. Her LVEF ejection fraction improved to 55%. Her urinary albumin creatinine ratio became less than 30. Now she feels more active, more healthier. So friends, concluding that I found this empagliflozin and linagliptin combination, it works wonders in selective group of the type 2 diabetic patients. So thank you very much.